BSI, scene safety, using standardized precautions. When I come up to my patient, being pediatric, I'm going to assess the patient's age, getting my general impression, whether they're an infant, toddler, preschool age, school aged. Knowing so that this is a pediatric patient, I do have an infant doll. In this scenario, of course, more than likely, parents or parental guardians will come up telling me what seems to be wrong with their child, etc. So I'm going to come up to my patient. First off, I'm going to start with assessing the patient's motor function, maybe by pushing on their feet, actually seeing their responsiveness. Okay, baby, can you hear me? Can you hear me? Alrighty. While working, I'm going to work from the feet up to the head, so I'm going to assess the patient's pedal pulses, assessing their dorsalis pedis, noting any deformities, contusions, abrasions, punctures, lacerations along their legs. Working up their legs, I'm going to assess their femoral pulse, noting that there is a pulse there. While continuing to work my way up, I'm going to gently press inward on the pelvis, pushing in, noting, looking at the patient's eyes, their expressions, noting that the patient looks like they do not feel any pain. I'm going to assess the patient's abdomen very softly, working away from if I see any distension or anything, noting of that nature. I'm then going to assess the patient's work of breathing up in the chest area, still noting that there are no deformities, contusions, abrasions, punctures, decap, BTLS of that nature. So I will then assess the baby's work of breathing, listening to the lung sounds maybe. So I can't really tell the baby to breathe, so I'll just have to listen to their respiratory. So breath, 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 breath. Okay. I will do so on the back side once I finish with the patient's front. So while doing so, looking at all this, I'm going to see the patient's color. Maybe the patient has skin turgor along their arms. While I'm assessing, I'm still assessing for any deformities, abnormalities, lacerations, punctures, things of that nature. Maybe the baby might be wincing whenever I am applying pressure to their arm, legs, abdomen, their chest, assessing their clavicles, feeling for any possible fractures or possible crevitus. So feeling so, now I'm going to work my way over to the arms and the shoulders, feeling the pediatric patient's bone structure along with musculature. I'm going to assess if the patient has brachial pulses. The patient does in fact have brachial pulses. I'm going to work my way down, assessing to the hands and fingers. This is where I would look for the skin turgor, along with anywhere along the patient's feet and legs. So I note that they do not have any poor skin turgor, still looking for any signs of low perfusion. So continuing to work along the patient, I'm going to assess the patient's neck, so making sure that I do have an inline trachea, noting of any possible abnormalities along with that. So now I'm going to continue feeling for the sides of the neck, noting on the back side of the neck if there's any signs of step off of the cervical spine. Also feeling along, working my way up to the patient's face. They may or may not allow me to do so, so I may have to do this in a quick, orderly fashion. But with the skill, I'm going to go calmly and slowly if the baby will allow me to. So I'm going to work my way around the mandible, feeling for any deformities, possible maybe air pockets along things of that nature. Now I'm going to assess the baby's mouth. I'm going to look for any signs of cyanosis along the lips and the nose. I'm then going to open the baby's mouth, assessing for any airway obstruction, noting their the color of their tongue, along with smelling the odor of their breath. I will then continue noting the color of the gums, whether they have teeth coming in or not. That might explain why they might be on edge recently. So now I'm going to come up to the zygomas, lightly pressing, feeling if there's any deformities, maybe contusions, which are bruises, abrasions, lacerations, cuts along the face, scratches. Also palpating and feeling around the eyes. So I'm going to look and assess the pupillary function along with the accessibility of the patient's eyelid, because maybe the patient has a foreign body in their eye and it's just becoming irritating to them. So now I'm going to work to the top of the patient's head, feeling for any deformities, contusions, abrasions, punctures, lacerations, things of that nature, feeling, kind of moving their hair if they have any, making sure I don't miss any abnormalities. Now I'm going to come along to their ears, to the side of their head. I'm going to look for any signs of CSF, making sure that they don't have a skull fracture, noting any signs of maybe increased cerebral edema maybe. So I'm going to look at the ears. I'm going to look behind the ears for battle signs, making sure that it is not bruised, because that is also a sign of a skull fracture. So now that the patient has been assessed throughout the whole front portion of the body, depending on the MOI or NOI, which is mechanism of injury, maybe the patient was dropped, or nature of illness, will depend on whether or not, on how carefully I roll the patient. So let's say the patient has just a NOI, which is nature of illness, so it's medical. So I will then kind of calmly pick up the patient. Okay, I will kind of palpate the patient's back of the neck, assessing any signs of step off in the cervical spine, lumbar spine, so on and so forth, noting any abnormalities along. If I didn't already do the back of the legs, this would be a good time to do so. Still feeling, looking, making sure that I do not see any bruising along the patient's back, all the way down into the coccyx, feeling for any bruising, deformities, and abnormalities. So with this being said, I do not see or feel anything along the back side of this patient. So while doing so, maybe at this time I'll ask my partner to listen to breath sounds along the back, just to get a better listen to their lung perfusion. I'm going to also continue to assess their heart rate. I may or may, depending on the age, may or may not be able to get a blood pressure on this patient or an SpO2 reading. But if the patient is in fact old enough and big enough, I can place a PD blood pressure cuff along the patient's leg to get that femoral pulse. With this patient would not be big enough, so I'm just kind of assessing what I see and what I feel. So now I'm going to continue to reassess this patient. At this point, I might be able to, if my partner has not done so, I'll be able to get maybe the length of this patient, how much the baby weighs, continuing to look for any signs of cyanosis, the color of the patient, their temperature, their color, their condition that they're in, noting any signs of their hair, scalp, tongue, mouth, looking for any abnormalities at all. So with seeing this baby, I do not see any abnormalities. If this baby is maybe acting different, I can ask the patient or the patient's parents if they are acting abnormal, meaning if they are rambunctious or if they are very slow and kind of not really calm, they're just kind of out of it, noting any differences that they may be seeing. So with going over this, once again, I've looked over this patient, making sure and assessing that they do not have any open, closed wounds, such as fractures along the legs, arms, tracheal deviation, things of that nature would be stuck out. So depending on the age, the patient may have eye contact, so whenever we're getting into A&O times 4, we can't really assess whether the patient knows person, place, time, and event, but we can see how they're acting and ask the parents once again if this is normal or abnormal. So doing so, I'm going to continue to assess this patient, noting if we need to transport the patient or stay in play. So that was my toe to head assessment since it is pediatric. Now I can come back and do my secondary assessment, maybe noting anything that I didn't see before, such as maybe their end-tidal reading, their work of breathing, things of that nature, continuing to get history from the parents.